Welcome to part two of the online lecture series for the injury evaluation process. Today, in this online lecture, we will be discussing the HIPS process, in particular the HIP component, history, inspection, palpation, and we'll leave the special test component for the actual lab course itself, where we'll spend all of our time discussing special tests, appropriate special tests to use in each joint for each pathology. So today we're going to focus on history, inspection, and palpation, spending an in-depth amount of time on the history component, which should tell you that history is a huge part, or history taking is a huge part of becoming a really good injury evaluator. In fact, some of you are probably sitting here saying, do I really have to listen to this? And I'm going to argue that the answer is yes, and here's why. Not because I'm giving the lecture, but because any good clinician is good at injury evaluation. They are able to assess any injury that comes in their clinic, and they're able to diagnose it, refer it out, and or treat it. But in order to do that, you have to understand the key components to a thorough injury evaluation. If you get this, then your clinical rotations will be smoother. Your fear of evaluating patients will reduce. And when you leave us, you'll be an efficient, effective clinician who's capable of not only just evaluating patients, but getting those evaluations correct based on what you're asking or what you're doing in the injury evaluation process. So let's go ahead and talk about musculoskeletal assessment as a whole, because before we can actually talk about the specific components, it becomes important for us to take the 3,000-foot view of musculoskeletal assessment. What we know about musculoskeletal assessment is that it's going to involve the hips or the hops component to it, right? This is every musculoskeletal assessment that you will perform. So if we are looking at this image on the slide, then what we want to look at is, where do we start? Where does any good evaluation start with our patients, right? And the first place that we start is with patient history. So we're going to spend a few minutes talking about different types of histories that you will take along the way. But our first stop is with patient history. Now, some clinicians would say, okay, when our patient's sitting in front of us, the first stop is patient history for sure. But one of the key components to truly being able to get a true good gauge of how our patient is actually doing is in the inspection or observation phase of the patient. In other words, this begins the moment that your patient walks into your clinic and doesn't know that you're actually looking at them, right? You've seen those patients walk into the clinic and they're happy-go-lucky, they're high-fiving their friends, and then as soon as they see and make eye contact with you, they start limping, or they grab their shoulder, or they start grabbing their back, right? Well, in your observation, you just saw them high five. You just saw them bend over to pick a piece of paper. So you already know maybe that low back pain isn't as bad as they're going to tell you it is when you start evaluating them. The other thing is the patient who wants to get back to practice, but maybe doesn't tell you all of the information, right? So inspection would allow you to see that patient limping, even though they tell you their ankle doesn't hurt. Inspection would tell you, oh my goodness, instead of picking up the pin with their right hand, they picked it up with their left hand. So that right hand must actually be fractured. So the observation phase is hugely important in musculoskeletal assessment. It's hard though in the big scheme of things, right? Because as clinicians, we're surrounded by student athletes in the clinical setting, and we might be busy, which means we might not always catch a glimpse of what that patient looks like once they've entered into the clinical setting. But you certainly can observe them as they walk out of the clinic and you're done with your patient evaluation, right? So there's different ways to kind of use the observation phase of hips or hops. Next is where you'll spend most of your time, right? It's in examining that patient. But part of patient examination involves many different things. First and foremost, it's going to involve palpation. So we're going to start with palpation. We're going to look at joint play, probably going to assess reflexes and sensation, in particular if we suspect a peripheral nerve injury. Remember, we talked about the neuropraxia, the axonomesis, the neurotmesis, right? If they have signs and symptoms that the neurovascular system is involved, then we're going to test those reflexes and sensation. We're always going to use special tests to help us rule in or rule out pathologies, that process of differential diagnosis. And then finally, we're going to look at movement testing. So how well do they actually function if they are doing something that's very sports specific? One component that we also have to consider is, once we're done, right? So once we've taken our patient history, once we've observed that patient, once we've examined that patient and we've determined what our diagnosis or assessment is, Then do we have to refer out for further treatment to a physical therapist, to a surgeon? Do we need more lab tests or diagnostic imaging? Lab tests meaning blood results. What do we need after that to ensure that our patient is going to return to play as soon as is possible? So I hope this makes sense, right? You're getting the 3,000-foot view, and now what we're going to do is kind of break this up into its components: history, observation, and then the key components to examining the actual patient itself. So let's go into evaluation strategies, because in the clinical setting there really are two different techniques to evaluating a patient in terms of actually palpating that particular patient. But what we want to really consider is the following: that in any patient that we work with, we always want to perform the task, whether that's a special task, a movement task, a functional task, right, on the uninjured limb first. And there's two reasons for that. Number one, we don't want to injure our patient because they're apprehensive. But then the other component to that is the uninjured limb serves as a baseline for us. It allows us to see what normal would look like for that particular patient, right? And then we are going to perform the task on the injured limb, right? Now we'll see some clinicians who perform the task on the injured limb first, right? And I do not recommend this for many reasons, the two that I alluded to before, right? So my question to you is, what do you think? Does performing a task on the injured limb, is it going to increase apprehension or decrease it? And the answer is it's going to increase it. So we should always be performing that task on the uninjured limb first, right? We're always going to ask all of these questions here. So we're going to take a history, we're going to inspect, we're going to palpate, we're going to do that functional assessment and stability test, special test. Now I circle this and say neurological tests won't always be done, and I've already alluded to that in the slide previously. And same thing with vascular screening. That's only if we have traumatic injury such as a joint dislocation would we want to determine whether or not we're getting blood flow and fractures right to the distal extremities. Next slide, what we're talking about is clinical assessment and really truly being good stewards of our athletes' time, right? So there are two different types of assessments that we can do in the field of athletic training. We can do a clinical assessment and we can do an acute assessment or an acute evaluation. A clinical assessment is one in which we do this in-depth patient evaluation. So that patient sitting in front of us has 30 to 45 minutes to allow us to truly evaluate them, to go through movement testing, special tests, reflexes, joint palpation, patient history, etc., right? That patient has enough time to do that. On the opposite end of that, we have our acute assessment or evaluations. These are the evaluations that are going to be abbreviated. We're going to skip some of the steps in the HIPS process because that patient is in a competition and we need to know if they can return to play, right? Does that make sense? So we spend more time with our clinical assessment, and this is more of a rapid evaluation, which is most often used to return a patient to practice right away or to competition right away, right? You need to know the difference, right? If you are on the sideline of a basketball game and your star point guard rolls his or her ankle and comes off and asks you to evaluate, you're not going to start with history, right? Hopefully you already know that patient's history. We're going to start with special tests, determine if there's laxity, and determine if we can tape them and get them back to play, right? That's abbreviated. You have to be able to distinguish between when you're going to do a clinical assessment and when you're going to do an acute assessment, because this will make your preceptors and your athletes trust you more if you can really have that good judgment, right? Now, in the clinical setting, we do have special considerations. And number one, first and foremost, is discretion. An example of this would be for both our female and our male athletes. We always assume that males want to take their shirts off and let us evaluate them. But there are males who are very self-conscious and aware of their pectoralis region or their abdominal cavity and don't want to take their shirt off, right? Same thing with females. We shouldn't ask a female to take off her shirt, even in the event that she has a sports bra in the center of the clinic. Most often, we should be using a patient evaluation room when we are going to be assessing sensitive areas, right? The groin would be another region. Anything in the pectoralis region, which will require student athletes to take off their shirts, that would be another region. So we want to use discretion about the joints that we are evaluating. There are some religions that do not allow for the evaluation of opposite sex healthcare practitioners. So you need to know your student athletes. You need to know what their preference is, right? The other thing that we've encountered is there are times where student athletes can't go into surgery if the surgical room isn't prayed over, right? Sometimes they can't give blood. So these are all things that you have to consider in the bigger scope of your practice. And then there's this thing called informed consent. So we know about this and we'll learn about it in our first clinical class. But informed consent really is this idea that we assume the patient will want them to help us if they are unconscious, right? Most often, though, patients will sign a written consent form about the things that we can do with them or things that we can discuss with other people, right? Such as their coaches, etc. All right, moving forward. So, in terms of injury, there are three really different types of onsets of injury, right? And we've discussed this in the summer, but we'll review it really quick. The first type of onset is sudden, right? This is acute. It's macro trauma. It happens right away, right? I run, I invert my ankle, I have an acute ankle sprain. That's sudden. That's a macro trauma. You have an insidious injury, which is as a result of micro traumas. So I continue to run, I increase my mileage, and I have medial tibial stress syndrome that progresses to a stress fracture. That developed over time, microtrauma after microtrauma after microtrauma. The other onset that we really haven't spent a whole bunch of time talking about is this it comes and goes injury. And you're going to get this. Most often, this is related to activity. Most often, it's also peripheral neural related. So they might have numbness and tingling that goes away at rest, but then when they participate in soccer, for example, the numbness and tingling comes back, and then it goes away again once they're done participating. That's what I'm referring to when I talk about comes and goes. Most often, though, what we're going to be faced with are these two. Either it's sudden or it's insidious, right? And we can go back to Wolff's Law or the SAID principle, right? This idea that the amount of stress and the amount of strain is hugely important, right? Again, if we don't have a lot of stress or strain, then we have atrophy, right? If we have too much stress or strain, then we have a macroscopic macro trauma injury or a rupture or a strain, right? So we want to live somewhere in here in this physiological range of treatment, right? Rehab, stretching, whatever it might be, we want to live somewhere in this what I call the gold spot or the jackpot. All right. So our first stop is with history, right? And I know that I've talked about it a little bit, but I want to really talk about it in detail now because we're going into a lower extremity evaluation course where history is extremely important. It's also important if you're taking the care and prevention course as well, right? So history identifies, number one, the mechanism of injury. That's probably the number one question that we ask is, how did you injure it? It is also going to identify previous or past medical history. Now that previous and past medical history we're going to talk about a little bit more. It could be you're asking about genetic issues, familial issues, or it could be as simple as just tell us if you've injured this joint before, right? There's different types of past medical histories. You want to ask questions about the underlying pathology. And then one of the things that we have started to do in the field of athletic training that's becoming more and more important is this idea of how is the injury actually impacting the patient's life, right? Because to me, that's extremely important when we're thinking about treating the patient as a whole, right? And I think this is an important concept, especially now in the times that we're living in, where mental health diseases are at an increased rate right now. So not only do we consider the mechanism of the injury or how it's impacting performance, but how is it actually impacting the student athlete's life? Has it changed? Do they stop going to classes because they no longer are participating in the sport they love? How does it impact that? And then I'm going to give you some tools or tips. When you ask history questions, they should always be open-ended and not yes/no questions, right? Unless, of course, they're critical. So, did you eat today? Yes or no? That's a simple yes/no question. But what did you eat today, right? That allows them to elaborate a little bit, and it allows you to determine, okay, why are they having stomach pain today or abdominal pain today, right? So let's keep continuing on and let's talk about past medical history. So in terms of past medical history, this is going to be done most often in the non-acute examinations or the clinical examinations component. And the reason it's done this way is because it takes a long time, right? And so we need to make sure that we have about an hour to an hour and a half most often to get a lot of the crucial information that we'll use moving forward. Most often this is done with our freshmen. So whether that's a high school freshman or a college freshman, and really doesn't change unless something changes, or they rediscover something in their familial history. So essentially with past medical history, what we're asking about or ascertaining is health conditions, previous injuries, any predisposing factors that they may have. So do they have hypertension? Did mom or dad have cancer and now they're predisposed to that type of cancer? History of previous heart attacks in their family, things like that, right? In addition to that, at this point in time in the non-acute examinations and past medical history, we're also going to ask for previous medical evaluations. We're going to get their immunizations and records, right? So all of these items we're going to be taking or getting from our student athletes, which is why it's so perfectly tucked into our physical examinations, our yearly physical examinations of our student athletes. All of this information can be found on box 1-3 in your textbook. So previous history questions that we want to ask: is there a history of injury to the body area on either side, right? So we don't want to just be focused on the right side that's injured. We also want to know if they've had previous history on the left side. What we know and what research suggests for like ACL injuries, for example, is that it's a history of previous ACL rupture on the other side that leads to ACL rupture on the current side. So that becomes a very important question to ask, not just of the side you're evaluating, but on the opposite side as well. And the other thing that we want to do, right, which I said earlier, is to make sure that we're comparing it to the other side, right? Do the current signs and symptoms duplicate the old symptoms, right? So in other words, if they've had this injury before, is it similar? Is it different? Because this will tell you grade of injury, essentially. And then, are there any possible sources of weakness from a previous injury? So an example would be, what we know about ankle sprains is that when a patient suffers from an ankle sprain, they have a high risk, 70% chance of developing or suffering from another and another and another, right? Most often, the reason for that is because there's a weakness or a laxity in the lateral ankle ligaments, right? So knowing this, it becomes important, right? Because it becomes, oh, okay, so you have a second ankle injury. Okay, this is to be expected. So as we're looking at this past medical history, it just becomes important to make sure that we're asking really good questions, right? As we progress into medical history, we get very specific, right? And so then we're going to start asking questions about their general medical health. So their current health status. Are they healthy? Are they on blood pressure medications? Do they wear glasses? Do they have comorbidities present? So maybe they have a mental illness and they're also taking medication, which causes, I don't know, let's say some type of anxiety, right? So those are comorbidities. Then we need to figure out if there are relevant illnesses, and then if they've had lab work, right? So in other words, have they had blood drawn? Have they had a biopsy for skin cancer, right? These are all important concepts, important historical pieces of information that we need to know about our patients at baseline, right? And then we need to know about their medication. And believe it or not, we need to know if they smoke, which is why it's always a question on your physical exam, right? Have you guys ever noticed that? What we know about smoking, at least from an athletic perspective, is it decreases the patient's exercise tolerance. So in other words, they may not be able to exercise for as long. They may need to take a break because we know that it impacts the pulmonary system and pulmonary function, right? We know that they might be at an increased risk for cardiovascular disease, so we just need to know it. And then what I find interesting in particular as an athletic trainer is this right here. It's going to delay fracture and wound healing. So in other words, if they have that abrasion, if they have a stress fracture, the research suggests that smokers take longer to heal from wound injuries and fracture injuries. So this becomes important when you're working with this patient and progressing them along their healing timeline, right? And this seems like, oh my goodness, like, am I really going to ask this every single time? The answer is no, right? You're going to ask this one time, and that's typically when they either are freshmen coming into you or they are a transfer student coming into you for the first time. After that, you have them update that form, right? Every year. Did anything change? No, then there's no need to sit and have this conversation with our patients again. Okay, so other history questions that we want to consider and ask our patients. I think has the patient had any diagnostic imaging? Have they ever been x-rayed, MRI'd, CAT scanned before? This will tell us whether or not they've had injuries. Sometimes you'll find in the historical component of hips is that the patient forgets, but asking about diagnostic imaging, they might say, oh yeah, I totally forgot I had this x-ray to do this, but it was no big deal, there was nothing there, right? But they still have had diagnostic imaging. Is the patient on any medication? This becomes important so that you can detect behavior, right? So mental illness is one that I'm thinking of. ADHD, ADD, bipolar. We can think of a list of diseases that we really want to know that our patient is taking medication for. Another one that's common among females is birth control, and birth control becomes extremely important only because sometimes what they eat will interact with that. Sometimes in terms of menses, it may change the way that they menstruate, so it becomes important to know what types of medication your patient is taking. I would even add in here supplements, because sometimes supplements can impede return to play, so it becomes important to ask about supplements as well. And then one of the questions that we have to ask, and even if it's a written question, not an asked question, is abnormal physiological functions such as bowel and bladder, right? So some patients may have to go to urinate more often than others. Is that frequent? Why is that? Do they have an STD? Do they have some type of infection? What's the reason for this? We want to figure it out. And then, does the patient have any other complaints, right? So in general, you just want to ask that question. Okay, we're done with the history, but is there anything else that you want to tell me? And this goes back to that kind of open-ended question that we've been talking about, right? So far we've talked about past medical history, right? We haven't talked about the current injury yet. And so that's what we're going to dive into next. So now we're talking about history taking of the actual present condition, right? So the first thing we want to know is the mechanism of injury. How did the injury occur? And so we could say, okay, was it macro trauma or micro trauma, or is it off and on? Does that make sense, guys? So what was the cause? You want to then identify the structures involved. So what are the anatomical structures that are involved? We're always asking about snaps, pops, cracks, numbness, and tingling, right? And then we want to know about the onset and duration of the symptoms. So was it acute or chronic, and how long does it last? And I would even take that further and say, what makes it feel better and what exacerbates the signs and the symptoms, right? So these are the key historical questions that you want to ask for a patient who's sitting in front of you with a present condition, right? One of the things that we really have to get good at asking is about pain. And there is a generalized way to ask about pain, and I'm hoping after today's lecture you'll at least be more in depth in your assessment of pain, because pain can be predictive of pathologies. So with pain, what we want to ask is not only the location and the type, but what we also want to know is it referring pain? Is it causing pain somewhere else across the body? If it's a peripheral nerve injury, does it radiate from the spot distally or proximally, or is it just right where they're pointing to, right? What are the daily patterns from when they wake up to when they go to bed? What does that pain look like? Does it get better? Does it get worse? Does it stay the same? What happens with that pain? And then, like I alluded to on the other slide, what causes it? What causes more pain and what alleviates the pain? Because as a clinician, to me, this one's probably most important, right? Because we're going to avoid that when we're treating that particular patient. What are their symptoms? And then one of the key things is, what have they done to treat it, right? What have they taken? What have they done to intervene and help relieve or alleviate the pain that they have? Any effective traits, and then any disabilities or limitations. So in other words, what can't they do as a result of the pain? Now, talking about pain and asking these questions is really good. One of the hard parts that I find is actually getting patients to describe their pain. So I'm going to talk about a few different ways to do that. First and foremost, when we ask pain questions, we have to ask intensity. What's the intensity of the pain? And most often this is done with pain scales. So on this slide, you're going to see one type of pain scale, but clinically we typically use the visual analog scale. So on a scale of 0 to 10, 0 being no pain, 10 being the worst pain you've ever experienced, tell me where you are on the actual scale itself, right? I've seen other clinicians use this system here, the happy face or the extreme sad face. But you want to get a scale, And you want to do that every time you interact with that patient because there's goals there, right? Your goal as a clinician is if they're a 6 today, in 3 days you want them to be a 3. In 6 days you want them to have no pain, right? That's a clinical goal that you can set when you're asking that intensity question. We also want to know the duration of the pain, the frequency, the location, the type. Now, the type is a good one, right? Because what we're asking, is it sharp? Is it dull? Is it achy, burny, right? We could think of lots of different ways that a patient can describe that. Give them a list and let them select it. It feels like a bruise. Okay, what's that feel like, right? And then what is the pain associated with? Is it associated with movement? Is it associated with loading? Is it associated with stretching? What actually causes the pain? Just sitting? What is it? These are all good questions that help you really truly get at what the pathology is going to be. Now, one of the things that I've learned over time is that you can actually put pain on a scale. So we're going to look at pain and function, and we're going to put it on levels, right? And so a level 1 pain is one in which they have pain after a specific activity, right? What we just looked at on the other slide was very subjective. The patient was telling us. Now we can take their subjective, what they tell us, and put it into a more quantifiable, objective assessment of their pain and function. So a level 1, if the patient says, oh, I only have pain after a specific activity. And this is good, right? Because it's not like they're having pain throughout their day. It's not like it's bothering them until they actually exercise, after they exercise, right? Okay, then a level 2 is they have pain at the start of activity, but it resolves with the warm-up, right? So this patient is still pretty functional. Why? Because the reality is if we do a warm-up before they actually go participate, they can still compete at a high level, right? Your level 1 and your level 2 still can compete at a very high level, and you won't see a decline in their performance, right? With our level 3, they have pain during and after activity, right? It doesn't affect their performance, but they still have pain during. So what you might see is that, in fact, they alter some of their activity in their performance, right? So they still perform at a high level, but instead of doing a single leg layup, for example, they do a jump stop and shoot the ball in the hoop, right? That would be an alteration. So they're still functioning at a high level, but they're altering their performance a little bit, right? When we get into the level 4s through 7, it's where there's concern, because what we know is that it does affect performance. That pain does affect performance. So that athlete reports pain during and after activity, and it's affecting performance. So this is when we say, okay, we probably need to remove that patient from play until we can reduce the amount of pain and improve function, right? Level 5 is pain with activities of daily living. So it doesn't matter what they're doing, it hurts. Then level 6 is that constant dull ache at rest. But the key here is that it does not disturb sleep. So we're not thinking stress fracture, right? Does that make sense? We're not thinking systemic cancer because it's not disturbing sleep. It's when we get to level 7, right, that we're concerned, because that aching pain has now progressed to waking that patient up at night. So probably need to refer out for some imaging. I really like this scale because as a clinician, it allows us to take what we get from our historical perspective from our patients and truly objectify it, and will allow us to make treatment decisions based on what they described, but on an objective scale. So I hope that you guys can use this in your clinical practice. One of the things that we have to also consider is not the type of pain, not pain and function, but also the duration of the pain. And this becomes extremely important when you're thinking about chronic pain, right? So that pain that lasts the entire season. Those are the athletes that, oh my goodness, are so very difficult to treat. So in terms of pain, we typically put it on a day scale, and we say, okay, acute pain is something that's going to last 7 to 10 days. So if they have an acute injury, right, we would expect by about 10 days that pain should be reduced to 0 if we're treating them well and effectively and efficiently. There's an assumption there, right? Subacute pain, so let's say we have a traumatic injury, and so then that pain could last up to 6 weeks, right? So we have a 2nd or a 3rd degree sprain, and so that pain may last 7 weeks. The pain that we're most concerned about is the pain that lasts longer than 7 weeks, right? Because then that's progressing into the season, and so then the concern becomes, is it going to limit their ability to truly perform, right? The reality is we don't want patients to have pain for more than 10 days. If they do, the question is, what are we not doing in our treatment? What did we miss? And maybe we should reevaluate that to see what's going on and is driving that painful mechanism. So the next created basically a schematic to allow you to see what things you should be doing when you have a patient who comes into the clinic. So if they have that acute pain, right, that acute pain is going to last about 7 to 10 days, give or take, right? And so in this phase, what we really hold as key to reduce that pain within that 10-day time frame is we have to evaluate that patient right away, right? Because if we evaluate that patient right away, then we're able to start treating them, right? We're able to start reducing the swelling. We're able to impede all of the inflammation that's going to happen. And so as a result, they are in less pain for a shorter period of time, right? So that kind of segues into this part. If we evaluate, we're able to treat them right away, right? And then they heal, right? So there's this progress. They're able to heal through, and we're able to release them, right? But if we don't, if for some reason we don't evaluate them in a timely manner, so this is the patient who goes through the pain and then finally decides to come to you, right? So we weren't able to evaluate it when the injury first happened. Well, then we don't have timely treatment and care of the patient. And so then as a result, what we typically see is that patient doesn't heal. So that pain lasts longer than 7 to 10 days, right? So this is pain that may last 10 days to 7 weeks, right? Because we couldn't treat them timely. So the key here is now we have to intervene right away. We have to come up with an aggressive treatment plan to reduce the pain, because now the inflammation is there. Now the atrophy has set in. Now the muscle spasm might exist, right? And so in this particular case, we also have to consider other items. Number one, if a patient has been removed from sport for an extended period of time, are there psychosocial issues that we also have to treat, right? What we know about pain is that there is a psychosocial component to it. This is research that supports this, right? So not only are we treating the injury, but we also have to treat the psychosocial component to the athlete that's sitting in front of us and has been in pain for more than 10 days, right? So in this case, we're going to slow down the recovery. We're not going to rush them to return to participation. And we're really going to work on reducing pain. But if we're a clinician and we don't slow down the recovery, we're in a rush, we want them to compete, they're in season, then what we typically will see is this right here, the development of chronic pain that lasts at least 7 weeks or more. And so pain has persisted beyond the anticipated healing time. And so now we have to figure out, okay, what's the causative factor, right? So why is this happening? And then what are we missing in terms of their pain? Do we need to do blood workup? Do we need to refer out to see what else is going on? And then with these patients, we treat them conservatively. And coaches do not like this because it means we may not have an athlete return to play for the entire season. The goal is to reduce the pain. The goal is to work on those psychosocial factors, and then we can return to play as is necessary. All right, so moving forward to the end phase. We've gotten through history, and now there's inspection, right? Inspection involves two components. First is observing the patient walking into your clinic, but then inspection is also honestly one of the most intimate parts of evaluation besides palpation. You have to be able to see the body part, right? And that's going to require that patient some time to get undressed. Now, remember, I alluded to this already, take them into a separate treatment room and evaluate them if we are dealing with discrete anatomical structures. You always want to explain everything that you're doing with the patient to the patient so that they have a good understanding. And then there are two key concepts that I want us to really think about. Normal is not normal to everyone, right? What I would consider normal, I think every guy should be able to take off their shirt and not think about it, right? That isn't normal to the guy standing in front of me who has body issues, right? So we can't take our normal and try to apply it to our patients. It's what makes the best clinicians. We're able to treat the patient sitting in front of us. And then is what you are seeing what you are seeing. So here's the thing. We're going to have a good history by now. We're going to know what type of pain they're having. We're going to know their previous history, injury history. And so now the question just becomes, make sure you're doing a thorough inspection. Make sure that what the patient is telling us is absolutely what we are seeing. And if they're telling us something different than we're seeing, we always go with what we're seeing, right? All right, so let's get into it. Immediate observations. As soon as the patient enters into the facility, we're observing them. We're observing their gait, we're observing their function, we're observing their posture as much as is possible, right? In physical examination, we're actually looking at them. What we're looking for is deformity. We're looking for swelling, in particular this hemarthrosis, which is something that looks like this, right? It's ecchymosis, it's bleeding, right? It's redness on the outside of a joint or a muscle, right? We're going to be looking for swelling, and we're going to have to take girth measurements, which we'll do in the lab class. And then again, we're looking at that skin color as well, right? Last but not least are signs of infections. Want to make sure that we are looking for that. So that would be redness, that would be warmth, that would be a pus oozing from the skin. These are all things that we can see. Warmth, probably touch, that's going to be more palpation, right? Okay. The next thing that we want to observe is the overt pain behavior. So do they guard? If you ask them, if they have a shoulder injury and you ask them to get up on a tall table, do they not use that shoulder to help thrust them up onto the table? Do they hold their shoulder close to their chest because they're afraid to move it? If it's maybe a neurological or neurovascular issue, are they rubbing the injury? Do they grimace just thinking about it? Are they sighing, right? These are all overt pain behaviors, yeah? All right, in terms of red flags, the big keys in which you say, I'm just going to refer out: severe unremitting pain, pain that does not go away, refer it out. Pain unaffected by position and or medication, refer it out. Severe night pain, positive, want to refer out for an x-ray, right? To rule out any fracture if it's a bony pathology. Severe pain with no history of injury, here we're thinking like a fibromyalgia, so something more systemic in nature, refer it out. Severe spasm that cannot be relieved by massage, by icing, by stretching, we want to refer it out. And then any psychological overlay. The patient communicates to you that because of the pain, they just can't live life anymore, right? Refer it out. All of these are reasons that we would refer out a patient in our clinic, because they are things that we cannot see, that requires either extra labs or extra films. Okay, guys? All right, as we progress, in terms of inspection, one of the things that we are able to do is look at the patient's level of function, right? So if a patient can, we're going to have that patient perform functional tasks, and those functional tasks should really be sports specific. Does that make sense? So if I'm a soccer athlete, I'm going to have the patient go out to the field and dribble the ball, stop and go, slide tackle, do all of the things that their position would require of them, or that were identified as problematic, because this allows you to see them in their environment, right? And it allows you to see where the deficit exists or impairment exists, if one does exist. So you identify those and then you measure them, right? And measurement's going to look different, right? Measurement compared to what they were previously able to do. If it's range of motion, which we'll get to in the next online lecture, then you can compare that. If it's strength, then you can compare that as well. So physical examination. The goal of physical examination is to rule out any catastrophic injuries first. And this is through the process of differential diagnosis, which is a separate online lecture, right? But anytime we go into the injury evaluation process, we go into it thinking, what is the worst case scenario? What special tasks, what functional tasks, what inspection, what history questions can I ask or perform to rule out the most catastrophic injury, right? This will then leave the smaller group of pathologies that are available and allow us to come to a clinical diagnosis, right? So we identify impairments and functional limitations through the history, through the inspection, right, process. And then finally, once we've done that, we get to the palpation phase of life. And so palpation is the art of touching your patient. You will become skilled at that. If you are soft, if you have a softer touch or a heavier touch, you will learn that you need to be somewhere in between. But in terms of palpation, there are two different types of ways that clinicians should palpate their patients. And there are two sequencing strategies. The first sequencing strategy, which you can see here, involves palpating all of the bones, all of the ligaments, all of the muscles in a specific order. So if I see a patient come into my clinic, they have an ankle sprain, I'm going to palpate all of the bones in the ankle first and see what's palpable to pain. I then am going to go to my ligaments and palpate all of my ligaments, laterally, medially, plantarly, and dorsally. I'm then going to go and palpate all of my muscles and tendons in each of the compartments. That's a sequencing strategy. And this is important because what it does is it keeps you systemic in your evaluation. I cannot tell you how many times if you're not systemic, if you don't have an ordered approach, how often you forget to palpate one thing, one anatomical structure, and that happens to be the injury, right? So I want to encourage you to choose a sequencing strategy. Sequencing strategy number 2 is to palpate all of the structures in no particular order, but the goal is that you either palpate all of the structures proximally and then move distally to all of those structures, or start distally and then move proximally. So a little bit of a different approach. My favorite by far is sequencing strategy number 1, but you will have to choose what works best for you. You are the clinician. You're going to be living it. So you choose what works best for you. Whatever you do, just be systemic. Last but not least, when you palpate, you have to palpate a specific way. So I have 2 images up here, this one here and that one there, and they are intentional. In this particular image, what we see is the clinician is using 3 or 4 fingers to palpate one specific spot. And in this particular image, we see the clinician using 1 finger to palpate one specific spot. When you are trying to determine where a patient is point tender, this approach here does not allow for specificity. In fact, if you ask the patient where they're tender, they're not going to be able to pinpoint it. If you ask the patient where they're point tender and you use this technique, they're going to be able to pinpoint it. Since this allows you to be more specific when your assessment is aimed at determining where they are tender to palpation, right? We also want to palpate for trigger points or muscle spasms and change in tissue density. Now, I just told you that this technique wasn't good for point tenderness, but if you are trying to determine change in tissue density, then this is a sweeping approach. This is the approach that we want to use to determine change in tissue density. We have crepitus, which is the creakiness that we hear when a joint moves. So we're going to cup that joint and just have them move and feel for it. And then we have temperature, right? And if we're doing temperature, probably should be using this technique. This covers the history, inspection, and palpation component to hips. You'll notice that the S is missing. That's intentional. We're going to cover special tasks a ton in the actual lab component of this class. Looking forward to completing online lecture number 3, which will be about range of motion and strength assessment.